welcome to this Friday morning meeting hosted by the Department of Oncology. Our speaker today is Dr. Dineo Tshabalala, who is one of the senior consultants in the department, and she'll be talking to us about triple-negative breast cancer.
Morning, everybody. Did I unmute it?
Yeah.
Okay. As Mpoti has already introduced me, I'm Dr. Dineo Tshabalala. Now, be giving a broad overview on triple-negative breast cancer. So I'll just start with a broad overview on breast cancer. Globally, it's the most diagnosed or the number one diagnosed breast cancer in female patients. It's now surpassed lung cancer as the number one cancer diagnosed, and according to our National Cancer Registry as well. It's number one as in terms of cancers that are prevalent in females. And in the US, they have more than 260,000 new cases yearly, with 40,000 deaths each year due to breast cancer. However, due to their good screening programs, they are having less mortality and more early diagnosis and curable cases. So if we could also have better screening programs, we probably would have less patients presenting in advanced stages of diseases. And the pathology of breast cancers are those of different subtypes: luminal type breast cancers, HER2 enriched, triple-negative breast cancers, and there are other breast malignancies that can present in patients as sarcomas, phyllodes tumors, or lymphomas. And patients can also present with in situ breast lesions that are pre-malignant. Just quickly on luminal breast cancer, it accounts for more than 75% of breast cancers that occur in females, and males can also have breast cancer, and most of the time their breast cancers will also be of luminal type. There's luminal A, which is of a low mitotic activity and low histological grade, and tends to occur more in older females than the other age groups. The luminal B, which is a more aggressive type of breast cancer, has a higher histological grade and a higher recurrence risk and risk of metastases. And this tends to owe to its gene expression profile in luminal breast cancers. There's HER2 positive breast cancers that account roughly for about 20 to 25% of breast cancers that occur in females. HER2 breast cancers can present with hormone receptor positivity or negativity. And over time, we've seen that those that are hormone receptor negative tend to do better in terms of responses and overall disease-free survival and overall survival. With these more aggressive type of tumors like HER2 positive breast carcinomas, you want to achieve a pathological complete response when you start treating the patients, especially in your neoadjuvant setting. And we know that the complete response is predictive of overall survival and disease-free survival. With hormone receptor and HER2 positive breast cancers, they have more favorable outcomes than triple-negative breast cancer because they have targetable receptors, proteins, and other gene expression profiles. So as you can see with HER2 positive breast cancers, in the neoadjuvant setting, there's monoclonal antibodies like trastuzumab and pertuzumab. When given to the patient in the neoadjuvant setting, they then help with patients in terms of their overall responses to the treatment, and that translates to overall survival benefit and disease-free survival benefit. There's other drugs in the adjuvant setting and as second-line settings and in the metastatic setting. And as I said earlier, breast cancer can also occur in men, and by far and large, it's of luminal type and most commonly luminal A breast cancer. It accounts worldwide for 0.5 to 1% of breast cancers in men. However, in Central and Eastern Africa, we tend to have a higher prevalence in breast cancer in men, and about up to prevalence of 5%. And it's owing to some risk factors like some genetic syndromes like Klinefelter syndrome and high estrogen to androgen ratio from a number of causes. Triple negative breast cancers are tumors that express low or no estrogen or progesterone receptor positivity, and their EGFR2 receptor protein is also either negative or can be 1+. With triple negative breast cancers, they have a 16 to 20% prevalence of BRCA1 gene mutations, and because of their lack of expression of the estrogen and indeed the HER2 protein on the membranes, they lack a lot of targeted therapies out there. However, progress has been done in that when looking at the gene expression profile of triple negative breast cancers, you'll see later in my discussion, there's a lot of biomarkers that can be looked for, or with next generation sequencing and other modalities to check for biomarkers or gene expressions that can be targeted. It has a distinct pattern of metastatic spread, and that triple negative breast cancer will tend to spread more to viscera than to bone, and patients can present de novo with metastatic disease. And even with that de novo presentation, they've got a high likelihood of having brain metastases than other of the breast cancers. It also has a characteristic and unique molecular profile in that, as I said, the gene expression profile is very diverse in triple negative breast cancers, and that there's a lot of biomarkers that can be picked up in these tumors, as they have a very high tumor mutational burden. Triple negative breast cancer accounts for 15% of breast cancers diagnosed in female patients, and tends to occur more in younger premenopausal women. And it's more prevalent in Black women of Black descent, whether African American, Caribbean, Black females, and also Hispanic females more than white females. And there are other risks that increase the prevalence of triple negative breast cancer, like younger age at pregnancy, less breastfeeding, and obesity. These triple negative breast cancer also harbor BRCA1 germline mutation. And because of their increased tumor mutational burden, they also have increased expression of PD-L1. This is just a pie chart showing the prevalence of triple negative breast cancer. If you look at the blue, it's more the African patients, whether they're African American or Caribbean or not otherwise specified. And the others, Caucasians and other ethnic groups, are less. This is just an overview of the molecular and pathological features of triple negative breast cancer. It's of a high histological grade. It's got a high proliferation index. It tends to have a geographic necrosis, and most of them will harbor a BRCA1 germline mutations. If you look at immunophenotypic characteristics, we've already said that it doesn't have receptors for estrogen and progesterone, and the HER2 is also negative. It tends to have EGFR1 positivity, especially in the basal-like subtypes of triple negative breast cancer. And this also just shows the different subtypes of triple negative breast cancer, where you can see there's the different types, but the common ones that are known are the basal-like, mesenchymal, immune modulatory, and luminal androgen. And this also the different gene expression profiles. The basal-like are the more aggressive ones that usually will occur in the much younger females. so triple negative breast cancer can also occur in the older females, but in the older females, we tend to find a more indolent type of triple negative breast cancer, which is the luminal androgen type of breast cancer. Just to talk more about the pathology and molecular and gene expression profile of triple negative breast cancer, it's very heterogeneous in that it's very diverse in its gene expression. We've already touched on it having the most common histological subtype of triple negative breast cancer by far is infiltrating ductal carcinoma, accounting for more than 80% of the triple negative breast cancers. However, you can also, if you have a metaplastic histological subtype, most of them are usually triple negative, and very rarely, but commonly, when you find a medullary carcinoma on histological type, it will be triple negative. We've already touched on the geographic necrosis, and these tumors tend to have a high stromal lymphocyte response in the form of stromal tumor infiltrating lymphocytes. These are biomarkers that are predictive in triple negative breast cancers for prognosis. So when your patient has high infiltrating lymphocytes in a triple negative breast cancer patient or any other oncology treatment, and predictive of achieving pathological complete responses with neoadjuvant chemotherapy. As I said, they tend to have a BRCA biomarker or tend to harbor BRCA1 gene mutation, and because of the increased tumor mutational burden, they also high expressions of PD-L1. They also, if you do next generation sequencing on your specimens, TROP2 expresses very high in triple negative breast cancers, although it's not unique to only triple negative breast cancers. You can find TROP2 in other breast malignancies, but it expresses exquisitely in triple negative breast cancer. At the moment, it is not recommended as a biomarker that needs to be tested for. I will talk later about this marker as well. So talking about BRCA, BRCA is a tumor suppressor gene. It's important for DNA repair. It's also important for cell cycle checkpoint control in terms of regulating P53. So if P53 is mutated, it just also tells you about the aggressiveness of the triple negative breast cancer. P53 mutation is very, very common in triple negative breast cancers. The BRCA is inherited in an autosomal dominant pattern, and it's important to know that with BRCA or BRCA-ness, for all breast cancers, it accounts for 5% of all breast cancers, the germline mutation. However, in triple negative breast cancers, the BRCA1 gene or germline mutation is more common and accounts for 20% of the mutations. In BRCA2, if you have BRCA2 positivity, it's more common in hormone receptor positive breast cancers, but in other hereditary carcinomas, you can have BRCA2 mutations like in prostate cancer, in pancreatic cancer, in gastric cancer. With PD-L1, it's a checkpoint receptor that limits T cell effective function within tissues. So it acts as a gatekeeper. So if you inhibit or if PD-L1 or PD-1 attaches on the ligand, PD-1 attaches on the PD-L1 ligand, it then suppresses your immune system. But if you inhibit that action of the PD-1 attaching on the PD-L1 with immune therapy, then you enhance the system to help in fighting the malignancy. So it's present in malignancies with high histological grade, like lung cancers, and indeed in triple negative breast cancer as well. So this is just a table just showing the 5-year relative survival rates of triple negative breast cancer. In the top one, it just shows you it's a CMJAH data showing you the five-year relative survival rates of breast cancer based on the subtype of the cancer. And if you can see, compared to your HER2 positive and your hormone receptor positive breast cancers, triple negative breast cancer has the worst outcomes in terms of survival at 5 years. And at the bottom, if you check, so it's localized and regional. If you check, if a patient with distant metastases, their 5-year overall survival is dismal at 12%. So it just shows the aggressiveness of the tumor and why these tumors need to be caught early and treated aggressively. I just have 2 cases to discuss. So the first one is a 30-year-old female patient, para-0, grav-0, with no comorbidities, had a grandmother who had breast cancer. She presented with a T2N1 left triple negative breast cancer. She then received neoadjuvant chemotherapy, and unfortunately, she recurred in the ipsilateral breast, or had progressive disease rather in the ipsilateral breast post the 7th cycle of paclitaxel. She then had to go for emergency mastectomy as there wasn't response anymore to chemotherapy plus axillary lymph node sampling. Post-surgery, she was found to have actually progressed from a T2 to surgery, and 1 month post her radiation, she had ipsilateral chest wall recurrence as she had a mastectomy with contralateral breast involvement, plus distant metastases in the liver and the lung. Unfortunately, within this recurrence, she demised within 5 months of that recurrence. The second patient is a 63-year-old female patient, and she breastfed all her kids. She also had comorbidities of diabetes, type 2 diabetes and hypertension, no family history, presented with stage 4BN2M0 triple negative breast cancer, had primary surgery with a left mastectomy and axillary lymph node dissection, adjuvant chemotherapy, post a month of chemotherapy, and 10 months post-surgery, she recurred with brain mets and lymphomatous meningitis. Then she, shortly after that, had lung metastases and demised as well. This is just to show the aggressiveness of this tumor and how if you don't test for biomarkers and try target some sort of biomarker, some sort of molecular gene expression, then unfortunately with chemotherapy alone, we're not going to win in treating these patients. So with the management of triple negative breast cancer, in the early stages where it's non-metastatic, it's important to know that, yes, when caught early and treated appropriately, the outcomes can be equivalent to non-triple negative breast cancer if at first treatment you do reach a pathological complete response. But even with early stages of triple negative breast cancer, you can have poor outcomes and shortened disease-free survival. And there's a high chance of residual disease after initial chemotherapy. So you aim to get a pathological complete response, but it's not at all times that you can get a PCR. And obviously the risk of recurrence is very high, not just for the primary site of the breast cancer, but for visceral metastases. Candidates for chemotherapy are any patient that has a tumor of more than 0.1 centimeters with lymph node involvement, axillary lymph node involvement, must receive chemotherapy adjuvantly, and those must receive oncology care adjuvantly. Obviously the standard of care is not, as first line at the moment, is not chemotherapy, but in our setting, we're still only giving chemotherapy unless there's a clinical trial. But in the neoadjuvant setting, if you have a T1C lesion, with or without nodal involvement, you must give neoadjuvant chemotherapy to these patients. For the longest time, there's been no targeted therapy for triple negative breast cancers, and chemotherapy has been the standard of care. And the regimens that were standard were to give an anthracycline with an alkylator, and then also add a taxane to it, or you could give all three together. However, especially with recent studies, they've seen that patients that are BRCA1 germline mutated have an exquisite sensitivity to platinum agents. So giving platinum with any of those chemo drugs enhances responses to the cancer. And as I said, PD-L1 is important to test because with a higher CPS score, or even you'll see as I present, even with lower CPS scores, you do have benefit, but the higher CPS score you have, the better the response to treatment. So with the Keynote 522 trial, patients were treated with chemotherapy and pembrolizumab, and the primary endpoint in this trial initially was to see if they'd reach a pathological complete response. And indeed, it was shown that if you did have PD-L1 positivity with a better CPS score, you actually did have better outcomes in terms of PCR and better disease-free survival and overall survival rates in patients with stage 2 and 3 triple negative breast cancer. In the neoadjuvant setting as well, post your chemotherapy and post initial oncology therapy and chemotherapy, if patients had residual disease on the specimen on histological specimen post your surgery, the Japanese at the CREATEX trial, where patients were given adjuvant capecitabine for either 6 to 8 months, and this showed to prolong disease-free survival in these patients and had an overall survival benefit as well. There was also another trial called Olympia. I've just added an extra A, but it's the Olympia trial, where patients with high-risk triple-negative breast cancer were initially given chemotherapy and went on to get surgery, were then given a year of olaparib if they had a BRCA1 gene mutation and had high-risk triple-negative breast cancer. And it was shown to also show a disease-free survival benefit. Management when it comes to metastatic triple-negative breast cancer also is important because we know that most of our patients, especially in our setting, present de novo with metastatic disease. And obviously our patients will have more visceral disease than bone disease. Unlike hormone receptor positive breast cancers, yes, they can have visceral bone metastases, but we know visceral organ metastases, but we know that if you have bone only metastases, your disease-free survival or overall survival rather tends to be a bit better than visceral metastases. And obviously we test for all of the high mutational burden and tumor infiltrating lymphocytes with the PD-L1 also aid in our treatment modalities and how patients respond to treatment. Till recently, chemotherapy was the standard of care. In 2020, pembrolizumab was approved as first, pembrolizumab with chemotherapy was approved as first line for metastatic triple-negative breast cancer. However, there was also a clinical trial prior to that called, there was Impassion 131, which didn't show much significance in terms of responses and progression-free survival. But Impassion 130, where they gave it to atezolizumab plus chemotherapy in the form of nab-paclitaxel, showed a progression-free survival benefit with a 20% reduction risk of progression to death, with 38% risk reduction in progression and death if you used atezolizumab. In Keynote 355, they treated patients with unresectable, locally advanced triple-negative breast cancer and patients who indeed had presented with metastatic breast cancer. And this was in the first-line setting, and they gave pembrolizumab plus chemotherapy. The choice was either with nab-paclitaxel or taxane, and platinums were also given as treatment in these patients. And what they did is that they divided patients into different CPS scores and according to their PD-L1. And the patients that were shown to benefit the most were the patient who had CPS scores of more than 10, where they had overall survival benefits of 23 months versus 16.1 months, and a progression-free survival of 9.7 versus. So you can see that with both studies, the Impassion 130 and the Keynote 355, there is a benefit in adding immune therapy to chemotherapy in the first-line setting. However, the benefits are not as overwhelming and as drastic as those we see in hormone receptor positive trials or in HER2 positive trials, where patients are given, or patients have better responses to those therapies given in those settings. In the metastatic setting as well for triple negative breast cancer, if patients had a BRCA1 gene mutation, there was the Olympia 80 trial where patients were given single agent of olaparib versus clinician's choice of chemotherapy if they had at least 2 prior lines of chemotherapy. And it was also shown that there was a progression-free survival benefit. Same with the BRCA trial, where they were giving talazoparib, which also was compared to chemotherapy, and there was also benefit in those trials in terms of progression-free survival. This is just a table that's summarizing your Impassion 131, Impassion 130, where you can see with the Impassion 130, there wasn't much of a benefit in terms of giving atezolizumab with paclitaxel versus giving placebo and paclitaxel. So the benefit was seen when it was given with nab-paclitaxel, and then Keynote 355 we've already spoken about. And this is a Kaplan-Meier survival curve, which shows survival of triple-negative breast cancer patients versus non-triple negative breast cancer cases at different stages, where you can see non-triple negative breast cancers in all stages do better than triple negative breast cancers. The worst outcomes and the patients who are metastatic. As you can see, that curve just shows the dismal responses and survival of those patients. Then earlier on, we spoke about TROP2 as a biomarker and as a target using the antibody drug conjugate. So TROP2 is not unique just to triple negative breast cancers. It just has a higher level of expression in triple negative breast cancers, but it is expressed as well in hormone receptor positive breast cancers, but tends to have an increased expression with triple negative breast cancers. And when you have this increased expression, it is also very much associated with distant metastases. So in the ASCEND trial, a drug called sacituzumab govitecan, which is an antibody drug conjugate that combines an humanized monoclonal antibody that is directed against TROP2 with a conjugate drug called SN38 that is like a topoisomerase inhibitor. and this targets TROP2. At the moment, how you would test for TROP2 is by doing next generation sequencing, but you would see it on next generation sequencing, but it's not a marker that has been suggested or is one that should be tested for upfront. But if you pick it up on next generation sequencing, so in this trial, patients were given this drug if they had relapsed and they were refractory to other lines given prior for metastatic triple negative breast cancer. So maybe in the first line, the patient was given, had a high CPS score and was given pembrolizumab and chemotherapy, and then progressed. And when they checked for BRCA, the BRCA1 gene was mutated, had a germline mutation, and was given a second line of olaparib, or then was given chemotherapy. These patients were then given this antibody drug conjugate, and there was benefit in these patients in terms of progression-free survival of 5.6 months in a patient that's gotten a lot of treatment prior to getting this drug, with an overall survival rate of 12.1 months versus 6.7 months. For triple negative breast cancer, this is decent, is a decent overall survival benefit compared to what we've seen as a benefit in these patients prior. So for me, I think more work can be done in this setting, because there's a lot of uncertainty when it comes to triple negative breast cancer. But also it's not an easy cancer subtype to figure out worldwide. So in our setting, there hasn't been a lot of work done. So all the work that we are referring to here is more in the Western countries. So maybe more work could be done in our setting to see if our biology is similar, and if molecular, pathological, and gene expression is similar to the Western countries. So I thought it was very important to talk about triple negative breast cancer, because there's not a lot of hype when it comes to triple negative breast cancer. More attention is paid to hormone receptor positive breast cancer because of the newer therapies, CDK4/6 inhibitors and the likes, and with HER2 positive or HER2 low now breast cancers, because there's a lot of drugs that you can offer those patients and not enough for patients with triple negative breast cancer. Thank you. I think it was short.
Okay, how important are environmental factors for those who are genetically predisposed to triple negative?
So very important. So, you know, we talk about germline mutation, but you must remember that you can have somatic mutations as well, which are mutations that develop from environmental factors, you know, whether it's the diet, you know, or recreational drugs like smoking and alcohol. So you can indeed also develop somatic patients that can then lead you to having an increased risk of developing triple negative breast cancer.
And how common is it in your department?
We see loads of patients. So in the commonest type of breast cancer that we do see is obviously hormone receptor positive breast cancer, but we see a fair amount of triple negative breast cancers. I mean, I think if we had to sit down and do a proper head count and possibly go to the lab as well and look over the past 5 to 10 years. In fact, Liska had a paper recently, and her data was similar. 10 to 15% of breast cancers are triple negative breast cancers. Yeah.
Thank you, Dineo. I mean, cancer is more common in people with cancers. Should we with some of the mammograms earlier?
I think the recommended age is 40, and the early detection help in this triple negative breast cancer.
So in terms of screening, the age isn't 40. It's difficult, and it just varies with where you are in the world, you know. But if you look at the NCCN and you look at other data, you know, they say from the age of 50 you should start screening. But of course, you know, populations are different. If you have, let's say, hereditary cancer syndromes in your family, then you need to test younger. Yes, at the age of 40, if you have a genetic predisposition. But if you're in the general population and you don't have increased risk factors, then from the age of 50, you need to start screening. Unfortunately, to also screen, we don't have the capacity to be screening everybody. But I would say from the age of 50 years, patients should start screening. If you have a strong family history, then start screening maybe age of 40, 45. Well,
yeah, so I think if you look at our Department of Health National Cancer Policy Guideline on breast cancer, they've recommended against screening because they just don't feel we have the money to screen for that on a population-based scenario. About 3 months ago, in fact, there was a nice paper with a large study that came out to show that actually 40 is your ideal age to start screening. There's been a lot of controversy in the last few years. Some countries have dropped their screening programs, but 40 does seem to be the sweet spot. Certainly, as Dineo sort of rightly said, you know, you want to screen 10 years earlier than the first index case in the family. You know, I think it's an excellent overview you've given us, Dineo. Thank you for highlighting. There's a lot of the new drugs that are not available just in the state sector. Pembrolizumab, atezolizumab, nab-paclitaxel are not available to us. But what we do have available is platinum. So I would recommend that all our patients who are getting neoadjuvant chemo get anthracycline, alkylating agent, taxane plus carbo as their neoadjuvant protocol. It's going to give you a best chance of pathological complete response. Any patients who have residual disease after that should get adjuvant capecitabine. And part of that is also us trying to get them into radiation early because these are high-risk cases. And if you delay your radiation, you can do all you can, but they're going to get early relapses. Early detection, I mean, that says it all. You're going to get a better complete pathological response in a small tumor than you will in a tumor that is over 5 centimeters. So, and pathological complete response is a surrogate marker for survival, and that's important. What can we also find? We've got a couple of nice clinical trials. Sacituzumab govitecan, which is the antibody drug conjugate, which in heavily pretreated patients showed significant doubling of overall survival. We now have a clinical trial in first-line metastatic setting. So sacituzumab govitecan at last costing, is not registered in South Africa as yet, but is registered in the US and Europe, is at about 700,000 Rand per treatment. So we can offer that to our patients in the form of a clinical trial in the first-line metastatic setting. We've just opened that study. Myself and one of my colleagues, Prof. Rappaport, are working on an investigator-driven trial to see that in our patients who don't have a complete pathological response, you know, whether we can use sacituzumab govitecan to rescue that prior to surgery, and that's currently going through ethics. And we've had Gilead, who is a company that produces sacituzumab govitecan, agreeing to fund the study for us. They really are looking for diversity and to be able to see in our South African Black population, do we have the benefit the same as what it would be seen in Western countries? So it's very important that we remember diversity. And then in the adjuvant setting, there's GloboH, which is a protein that is also being investigated. And there's a vaccine potentially for patients for GloboH in the adjuvant setting that we're also involved in the study. So we don't have everything, but you know, through studies and through tweaking what we do have, we hope we can offer patients a little bit of it out.
For me, with the screening stuff, and they don't touch on it, and then one which I'm very possible, they distinguish African patients age 42, Caucasian age 51. They went clearly and said that, and the logic behind that is because the African patients are doing worse in America. And we know this is happening in South Africa for colon cancer and other cancers. but you're not actively putting that information out there in the genetics research. Again, another thing about saying not doing enough genetic testing on our patients to direct treatment and options and stuff like that. So what's the access for genetic testing for state patients?
We do have it's very good actually.
When
Yeah.
established genetics departments, you do test really, if there's a under 40, you say under 40, and those with family history should all be referred to a test. So if you've got a young female, whether she's negative or not, and she's under 50, they should be referred to genetic testing.
And the other issue is the linkage to other cancers. We tend to forget about that with the multiple hit factors, the breast, the ovaries, and especially stomach cancers. So I think when we see patients, it comes back to history taking, focus on everything, not just on one organ.
Yeah, you both, Georgia, you've mentioned African diversity. So just in that respect, do you think there are differences in age of onset of patients developing or susceptible much earlier on in the African context as compared to the Northern Hemisphere, for example?
With triple negative breast cancer per se?
Yeah.
You know, in our department, we with triple negative breast cancer, we have a lot of young patients, and most of them are younger than the age of 40, right? And I think it's similar to European countries where they're seeing similar cases of really young presenting with triple negative breast cancer. However, we do have older patients as well presenting with triple negative breast cancer, but those patients tend to have just interesting to see what clearly it's not basal-like, but what is comments on those older patients. They usually give bicalutamide to those patients to target the androgen receptor, and the older, I'm giving capecitabine, and they either reduce or stay with stable disease for months on end. So I think our profile is similar. It just would be interesting to actually do some research on it and see more real life data.
I mean, just following up with that, there has been some suggestion of HIV, perhaps in the younger patient, playing a role in the younger patients. Do you think there's any possibility of HIV influencing the immune system, making a person more susceptible to?
So I think from the work, and I know Dr. Pagati and Dr. Kubash have done some work in HIV and breast cancer prevalence, not necessarily triple negative breast cancer. And from Dr. Pagati's work, there wasn't a real correlation, but we do know that with any disease that decreases your immune system, you tend to have a higher inflammatory response that puts you, makes you susceptible to develop any cancer, whether it's a lymphoma. Yes, we have seen an increased rise in patients with breast cancer, but I don't think it's specific for breast cancer. I think broadly, that state puts you at an increased risk of developing any of the malignancies. Prof?
I think if you look at triple negative breast cancer, a lot of the work now is looking at the biomarker and the milieu. So if you have a high tumor lymphocyte infiltration, you potentially have a better outcome in terms of your neoadjuvant chemotherapy. And I think some of the concern is, do you have a poorer outcome? Not necessarily is it a high incidence, but do you have a poorer outcome if you don't have that tumor lymphocyte infiltrate or TILs, as we have referred to them?
No, I mean, it's very the difference in the response to pembrolizumab is very interesting, I think.
But even in your where you don't treat chemotherapy, TILs do seem to be a marker of outcome. in the setting of triple negative. It's interesting because it's the opposite in your HER2 positives.
Yeah.
In your HER2 positives, patients who have got low TILs, in fact, seem to have a better response to your neoadjuvant treatment. So there's still so much we don't know about that review.
All right. If there are no further questions, thank you, everybody, and enjoy your day. So for CPD points, there are barcodes on the door.
Keep presenting it around. Sure. No, so Chuntaba ka present. Because sometimes I can't say stuff. Yeah. So I don't know. I was thinking, we haven't done anything. We can just start with kills for this Pfizer thing.